Welcome, everyone. I'm Paul Sorajja from Minneapolis, and I have the pleasure of welcoming you to tonight's Interventional Octagon, which is focused on transcatheter mitral therapy. This is part of our CVI Foundational educational series. We have an audience that's targeted as described here, as well as learning objectives, and this activity is accredited for ACCME credits. Tonight, I have the pleasure of moderating this session. Matthew Price, unfortunately, is not able to make it tonight due to unforeseen circumstances, but we have also Dr. Gagan Singh and Firas Zahr. So as I was saying earlier, the West Coast is very well represented tonight. We will be discussing 4 cases. We will be going in alphabetical order. Dr. Ahmed from Yale University, Dr. Shihab from United Kingdom, Dr. Ahmed Leary from Pakistan, and Dr. Warner from the Medical College of Georgia. You can see the disclosures as described here for persons participating in tonight's activity. And we also would like to acknowledge the very generous support of Abbott, Boston Scientific, Cordis, and Medtronic, who have helped make this activity possible. You can claim your credit here for CME with this QR code if you'd like to scan here. This is available as part of the enduring materials on our website. And please also note that our next intervention octagon will be focused on peripheral, and this is extreme CLI in no option patients. So feel free to submit your cases for that one, which will be coming very soon. Also, please keep in mind our meeting, the Operators Enclave, is this July 24th to 26th in Austin, Texas at the JW Marriott for cases like what we're describing today, as well as many others in more detail. Please join us in Austin this coming summer. For tonight's material, if you'd like to revisit it, it's part of the enduring material at our website, cvinnovations.org. There you can also find other webcast activities for CVI. So with that, I'd like to turn it over to our first presenter.
Great. Thank you, Dr. Sorajja, for the introductions and for this opportunity. So my case today is about intra-aortic balloon pump beyond hemodynamics. It was basically used to help in mitral clip or MTEER. So our patient is an 80 years old female. Her past medical history is significant for severe atrial biatrial enlargement with atrial fibrillation. She had a severe functional mitral regurgitation with severe pulmonary hypertension and dyslipidemia. She had frequent admissions because of acute decompensated heart failure. Her medication has been optimized, diuretics, yet she kept on having heart failure episodes. Her baseline NEHA classification is class 3. So the patient was discussed in a multidisciplinary team, and the plan was to fix up her mitral regurgitation, and the debate was whether to go for an open heart surgery versus a mitral clip or MTEER. And the decision was to go for catheter-based management, given her high surgical risk. Although the STS score was 6%, her frailty index was high. So the decision was to go for MTEER, for which she was admitted electively for the procedure. On admission, she was hemodynamically stable. She was on room air, yet clinically, she was a little bit in heart failure. She's having bilateral crackles, mild pulmonary edema. However, she was on room air. So right heart catheterization was performed, and that was during the procedure itself. And those are the numbers. As we can see, the wedge pressure is 41, and everything is kind of backlogged, or pressure is been recording high at the circulation at the back. PA pressure was high, 54, RV and RA pressures were high. TE was, of course, done during the procedure, and this is the TE view at the 0 angle. It's showing a severe mitral regurgitation with a wide jet at the center. Basically, there were a significant mitral regurgitation with a wide-based jet between the P2 and A2. The assessment intraoperatively was basically a procedure would be technically difficult because the coaptation gap was deemed to be big, 0.7 centimeter or 7 millimeter, as it was measured by the TEE. So the discussion during the procedure was we need to optimize this before we go forward. Otherwise, it will be difficult to capture the leaflets for the clip to be deployed. Intra-aortic pump ballooning was inserted to help in coaptation of the mitral valve. The science behind this basically is decreasing the afterload and helping the LV in the systolic volume and pressure. And hence that would help the regurgitation and the left atrial pressure as well. This is the TEE, intraprocedural post balloon pump. As we can see, the coaptation improved a little bit, you can see by the naked eye, and it was also reported to be improved from 0.7 to 0.3. Although it helped significantly, yet the procedure was technically difficult. The grasp was achieved, but after a few attempts, I believe 4 or 5 attempts was tried, and then the leaflets were being able to be captured and the clip was deployed. One clip was inserted at the A2P2, and this is the procedural outcomes. The MR improved from grade 4 to grade 1. The left atrial pressure reduced significantly from 20 to 12, and post-operatively, the patients, she improved like dramatically. Post-procedural on the second day, her symptoms has improved significantly. Her NIHA classification has improved. And in a follow-up of 1 month in the clinic, NIHA classification was basically 1. And up to 6 months, she didn't have any episodes of decompensated heart failure, and she kept on the improvement and the mitral regurgitation of only 1. So that's basically the case, or home message that intra-aortic pump might have a new indication in hemodynamically stable patients to justify mitral clip in those who are having a significant mitral regurgitation, functional mitral regurgitation. The coaptation is with wide coaptation and technically difficult procedure. And with that, I'd love to have any questions.
Thank you, Dr. Ahmed. So I have a few questions for you. And so this patient was in acute pulmonary edema. What was the blood pressure high? Was there room to actually just do medical therapy, or was this patient shocky or unstable that required, the heroics of a mechanical support?
So she was completely stable. Basically, she was admitted electively for the procedure. Her blood pressure wasn't more than 150, 140, I would say. She was maximized on diuretics and beta blocker in order to help the mitral regurgitation, even prior thinking of the procedure.
Gagan, for us, so this is along the veins of, maneuvers that make the procedure go easier, medical therapy, mechanical support, PEEP, all these things. What do you think?
Yeah, no, congratulations, Dr. Ahmed, to you and your mentor. Great case. I think it really highlights the use of MCS in these acute settings, and certainly patient selection is important. For patients with low EF, sometimes a balloon pump is needed just for induction more than anything else, just to get them through the induction, and then you can complete the TEER case without much difficulty. I guess the one question I have for you is that or maybe when as you become familiar with the case, I mean, the mean LA pressure was 20, I think, at the beginning of the case, which is profoundly elevated, and then maybe with some time, balloon pump, maybe with some more anesthetics, did you notice that the LA pressure came down after the balloon pump was inserted, and then came down even more after the clip, or did most of the reduction happen with the balloon pump itself?
Well, most of the reduction, I would say, happened after the balloon pump and the clip. I don't recall the numbers right after the pump inserted versus after the clip, but it's improved basically after I'll say day 1, day 2, and the echo, it showed improvement, and the LA pressure was recorded basically after the clip. I would say not the pump. I just can't recall it on top of my mind, whether the improvement after the clip or the pump.
Okay.
I did notice that your wedge pressure at baseline was 41. You had
That's
described
right.
that. And then in their slide, you said it went from 20 to 12, which sounds like it was during the procedure when the balloon pump was on. So there was obviously an acute effect from the balloon pump. I think this is actually interesting because it's normal EF. To Gagan's point, you know, low EF, we often may think of such things, but normal EF, maybe not so much. For us, what do you think? Oh, you're muted.
This is a fantastic case, and you know, and bring to us, you know, like we always face this dilemma, but when is the right time to do TEER? And you know, we try to do them with when the patients are totally compensated on medical therapy, and now the MR is not so bad, and then we wait a little bit until they get hospitalized, and then the MR is, you know, is too much. And I think this case just illustrate that beautifully, how dynamic the MR is and how little changes in afterload, whether it's pharmacological or with a mechanical support device, can make significant change in the you know, in the response to MTEER. You know, so congratulations, and this case just, you know, reminded me how many times we face those challenges, and you illustrated a beautiful way of managing it.
It makes me wonder if we should, you know, in these MTEER cases, just bring the blood pressure as low as possible for all of them, you know, and just try to optimize hemodynamics, just because then you're just going to get a better grasp. It's going to be easier, and maybe it's more durable. I don't know, Gagan, what do you think? Do you think we should be doing such things?
You know, and we have some great case examples of this where patients with severe flails, you know, there is the Paul Sorajja technique, which is you give 18 of adenosine and to grab these very large flails. And what I found is when you give 18 of adenosine and the patients, you know, obviously they arrest, everybody else in the room, sphincter just tightens quite a bit. And so what I found is in these patients with very severe flails is to actually just put the balloon pump in and get their blood pressure as low as possible, and I'll have the anesthesiologist put them on an esmolol drip. So now I'm operating with a low blood pressure, heart rate's in the 50s, and they're protected with a balloon pump. And we've actually seen some flail gaps come down, and it made the procedure a little bit more controlled. So I think that there is a large role for acute maneuvers, and this was a great example of that.
Yeah, even with relatively preserved EF, you know, I think for tricuspid, it's a very common thing to think about, decompensation, optimizing, trying to get better TEER results. But for mitral, I don't know if we really think about it too often, to be honest. I think we kind of accept it for what it is and then just try. But I really like the idea of trying to make things better with these maneuvers. So great case, Dr. Ahmed. Thank you so much for sharing that. We'll move on, Dr. Shahab, who's graciously joined us from abroad in the UK. So thank you. I don't know what time it is there. I actually hate to ask.
It's late at
I
night.
think I do know what time it is. So thank you so much.
2:15 in the morning, but yeah.
Oh, thank you. Gosh. Okay. Well,
Pleasure to be with
you
you.
probably just left the pub, so it's okay. All right.
It's how I deal with the nerves. One
Please
second.
go ahead.
Yeah, thank you. Good evening. Thank you for the opportunity to present this case entitled Invasive Physiology of Mitral TEER with Balloon Pump Support for Ischemic MR in Cardiogenic Shock, Left Ventricular Pressure Volume Loop Analysis. My name is Omar Shab. I'm an interventional fellow at Bart's Heart Centre in London and a research fellow in structural heart disease. So the case background is the case is of a 50-year-old diabetic female who presented late with a posterolateral MI and underwent PCI to her left circumflex artery, and despite that continued to deteriorate with worsening cardiogenic shock, resulting in admission to intensive care with escalating inotropic support necessary. An echocardiogram revealed severe biventricular dysfunction and significant mitral regurgitation that was thought to be new for her. Her ejection fraction, even with MR, was 15%, and she had impaired right ventricular function. And the mechanism was functional and mainly due to posterior leaflet retraction, with a 3D vena contracta measured at 0.84. Due to her rapidly deteriorating clinical status, a sort of emergency heart team was convened, and it was the consensus of that meeting was that essentially she was too high risk for mitral valve surgery, not a transplant candidate, and that her only real option was for salvage TEER with balloon pump support. Now, separately, as part of my PhD in mitral regurgitation, I ran a study called STRESS-MR, which is a prospective observational multicenter study that is looking into the hemodynamics and physiology of MR reduction, using transcatheter means, and then subsequent using through the prism of pressure volume loop analysis, and then looking at that on subsequent impact on health status. So this lady was recruited into that study. Now, there's not a lot of data, or in fact, hardly any, in terms of pressure volume loop demonstration of the effect of balloon pump support. But on a theoretical basis, if you can, looking at this diagram, a balloon pump, a patient receiving balloon pump support, that theoretically should trigger or should result in a leftward shift of the loop, which usually implies which would involve a reduction in afterload. Doesn't necessarily need to result in an improvement in contractility, but the reduction in afterload usually is coupled with an improvement in stroke volume or cardiac output, and through counter pulsation, an improvement in diastolic coronary perfusion. What I did manage to find is that in 2003, a group induced mitral regurgitation surgically in 8 calves, and did pressure volume loops on their, left ventricular pressure volume loops to try and demonstrate the impact or the effect of going from being in control with a normal ventricle, which is illustrated with loop 1, to having severe MR, which is represented by loop 2, and then severe MR with balloon pump support in loop, which is loop 3. And what you see is that huge contrast between the control loop and that flat and broad loop of mitral regurgitation with loss of that isovolumetric contraction phase. What they found with the in their study of these 8 calves was actually there wasn't much of a shift in terms of the loop with balloon pump support versus without balloon pump support. Contractility was no different. Afterload, the way they measured it, wasn't different, although they did see a significant increase in cardiac output. Now, looking at the hemodynamics of the patient in question, what you have here is her pressure volume loops at baseline with the balloon pump on and off, just before we were about to go ahead and do TEER. And the baseline balloon pump off loop is the solid line, and the balloon pump on is the dashed line. And what the indices show is that the balloon pump did bring about a 10% increase in cardiac output. As you can see, the cardiac output is very low. There was an increase in stroke work without an increase in pressure volume loop area, which essentially means that hemodynamic efficiency improved. Load-independent measures of contractility didn't change, and diastology was largely unchanged as well. We did see a drop in afterload, and therefore an improvement in LV to aortic coupling. The TEER procedure itself was uncomplicated and successful, with the deployment of 1 Pascal P10 device, resulting in mild residual MR, with a 3D vena contracted down to 0.15, and normalization of PV vein flow with a mean gradient of 4. Interestingly, as part of the study protocol, we measure LVOT stroke volume pre and post, and there was no improvement in the forward output, at the LVOT. Now, putting the balloon pump aspect to one side now and looking at the physiology pre and post using the pressure volume data without balloon pump support, what we see here, and that's depicted, so the baseline loop is in yellow and the post-TEER loop is dark blue. And you can basically see they're superimposed. The only real difference is that you'd get the impression that the stroke volume is reduced post-TEER, and that's only because the catheter in the LV doesn't know where the volume is going. So it thinks the stroke volume has gone down when actually the regurgitant volume has gone down. But other than that, contractility and all the other measures didn't really change, and that's validated, and that's backed up by the indices where you can see that cardiac output didn't really shift. There was a drop in pulmonary pressure, but hemodynamic efficiency, systolic properties, and diastolic properties were unchanged. We did see an increase in afterload and therefore a deterioration in LV to aortic coupling. So in terms of the outcome, unfortunately, there was no significant clinical improvement despite successful TEER, and the patient developed infection and died 3 days later due to refractory VT and low cardiac output state. So in conclusion, these patients are very challenging to manage with few options and often a very poor prognosis. The use of balloon pumps can improve hemodynamic performance, although patient selection is fundamental to identify those that are likely to respond, and there are certain factors that are likely to predict that. And TEER in patients such as this or in acute MR in general is quite unpredictable. Although in this case, the sheer degree of pump failure is likely to have been the key driver of her outcome. Thank you for listening, and happy to take any questions and look forward to the current discussion.
Thank you so much, Dr. Shah. And again, appreciate you calling in at 2 in the morning from the United Kingdom. I think these curves are amazing. And so I have a couple of questions and I'll turn it over. The first thing is, can you use the response to a balloon pump or any data in those curves to identify the responder or predict how the patient's going to do after MTEER? Obviously, this patient didn't do well, but are there signals in those tracings that would help us?
I think based on the data that from this patient individually, I'd have to say I don't think so, because there was just such little. There wasn't much of a sort of a difference in the physiology, brought about by the balloon pump. So it's hard for me to then go back and say, well, actually, there was this about the patient that was meant they were likely to respond. What I can say is that anecdotally, the balloon pump itself reduced MR, which is something we also saw in the last case. And we did see an improvement in the hemodynamics and the procedure tolerance. And when, for example, when I was turning the balloon pump off to record the PV loops and do several recordings at a time, you could really see that the patient was struggling, dropping pressures, and you could see the anesthetist getting quite frustrated and basically telling me to stop recording so we could turn the balloon pump back on. So you could see that in terms of clinically, we were definitely seeing a positive response to this treatment. And they got the patient through the procedure because they did reduce the MR quite a lot. And it may, and yet the patient remained stable throughout. And I think that was largely due to the balloon pump mitigating some of that afterload increase that we would have seen, and keeping the hemodynamics stable. I think the fact that the patient's SVR was quite high is one of the things that supports a favorable response to balloon pump treatment. Yeah. However, the fact that there may heart rates being septic, etc., all of those things kind of go against being a favorable responder, but that's more broad. That's not necessarily in the context of MR.
I guess what I saw in some of those curves is that your end diastolic pressures you actually came down on that relation. It looks like if you go back to one of your slides, you actually came, yes, this one. So you went from yellow to blue in the lower right-hand corner. So you actually came down on the EDPVR, right? So I would have hoped that you would have had some, but clearly it wasn't enough. Firas, Gagan, comments?
Yeah, I mean, this is I'll echo what Paul said. This is absolutely fascinating. And I think kudos to you and your group for highlighting kind of not the acute kind of changes that we think are happening, but based on this N of 1 in a very, very sick patient, who, like you mentioned, is probably more pump failure than MR. And certainly I think a lot of our centers would have attempted the salvage off-label high-risk tier to see if we can bridge the patient through. So, but the work you're doing here, I think, is absolutely fantastic. And certainly with the N of 1, I don't think we're going to learn as much, but certainly as you start getting your higher sample sizes and learn some of the changes, and not just this type of patient, but maybe a stable outpatient or somebody with mild decompensation, I feel the acute reduction in MR and the response to the PV loops is going to be different based on the patient's underlying physiology and their reserve. This patient didn't have any reserve whatsoever, and with a cardiac output of 2, that's terrible. So your SVR is high because she's essentially in pump failure. But really, I think great work, and I'm looking forward to seeing more of the PV loops in aggregate.
Thank you.
Yeah, if I have one comment, and Omar, I really thank you. PV loops at 2:30 in the morning, it got to be not an easy task, and really appreciate you doing that. And I wanted to tell you that this is fascinating, and every time we look at the impact of what we do in structural heart on the hemodynamics and the physiology, is we add to the little that we know about the management of complex valvular heart disease. So I think this will, as Gagan said, as you increase your sample size, we're going to learn tremendously from this. And I totally agree that that we're going to find different response, depends on the patient, the etiology of MR, the state that we treat them with, the residual MR. And I think that this might be the first thread in trying to find answers why some people respond better than others to MTEER therapy. So I think you're onto something big, and congratulations on this work.
Thank you. Appreciate it.
I just think it's cool how you have an end diastolic pressure volume relation down there with a couple of shifts in the curve. We got to figure out how to replicate this dynamically before therapy, so we can understand these EDPVRs and such.
Yeah, I think replicate and try to find some sort of non-invasive surrogate, right? Because I can tell you, the PV loops are great to look at, but man, to kind of do it yourself and to do the analysis, it's like watching, it's not as exciting, but certainly if you can do all the legwork for us and then find a non-invasive surrogate that could make it more practical, I think for everybody, I think would be kind of the best kind of.
I've always thought that if a PV loop were like IFR, they can just give an answer, that would be amazing. But
there are
patterns. Yeah,
there are some companies that are looking at flow dynamic and try to understand the pressure volume relationship through that. I mean, as an interventional cardiologist, it never look as real and cool as it does when you look at an actual Millar catheter PV loop. But I think that we might get there.
Yeah.
I mean, I have now completed recruitment follow-up, so the output should be soon. And most of them, in fact, the vast majority are elective stable, but very symptomatic patients. So you'll see it soon, hopefully.
Well, congratulations. Thank you so much. So we'll move on to our next presenter. We're going around the world. Next one's Dr. Larry from Pakistan. So a little bit later in the evening or early in the morning. I think it's 6 or so. I just Googled it. Thank you, Dr. Larry.
I'm Dr. Wade Ahmed Larry, and I'm a structural fellow at National Institute of Cardiovascular Diseases. So I'm going to present the case. Title goes like double challenge and double solution. It's a case of complex PVL closure. So the case is 30 years male is a known case of rheumatic heart disease. His height is 179 centimeter, weight is 60 kgs. He had a successful procedure of DVR back in 2007. He was doing fine, but last few months he was having complaint of massive shortness of breath in MIJ class 3. Well, the ECG shows atrial fibrillation with a controlled rate, and the current treatment is beta blockers, digoxin, laserite, and morphine. The labs had an evidence of hemolytic anemia with the subtherapeutic INR. So the recent echo was done, which shows an ejection fraction of 60% and dilated right ventricle with a depressed function. TEPC of 14 mm, and he was having severe DR with a pulmonary systolic pressures of 85 millimeters of mercury. The prosthetic mitral valve had a normal moderate severe paravalvular leak with variance of 26 and 9 millimeters of mercury with peak and mean. DVI was 4.2. And he had a prosthetic aortic valve with normal disc mobility, which was having a mild paravalvular leak. Variance were 54 and 28 peak and mean. So we further confirmed that transcatheter echo, the mitral valve was moving normally, but there was a small gap on the lateral aspect near the appendage, which was measured 3 millimeters. The peak gradient was 36 and mean gradient was 14 millimeters of mercury. So what we did due to the symptoms and the evidence of hemolysis, we these are the imaging clips in which you can see it, the Aortic jet, and that was on the 10 o'clock on 3D echo. So we took this patient to the cath lab, and the plan was to close the PVL. So we did, we went antegrade and we did a transeptal puncture. And after that, we advanced the, and then we took a diagnostic catheter inside, and we tried to cross it with a glide wire, and we were successful. And then we exchanged that pigtail, and we did a LV gram, so to see that whether we have a leak or not. And after that, we exchanged this on a super stiff wire, and keeping that, we had to take another parallel backup wire for the PVL. So what we did, we crossed that PVL parallel to this setup with a coronary wire, and then we took a diagnostic catheter and we exchanged it with a 3-5 wire. So confirming that we are through the PVL with the transesophageal echo. So we took an AV plug device through that PVL. Actually, this case is few months back, so I don't remember the exact size of the device. This was I'm sure this was the largest device available at the time of the procedure. So then we deployed the device by pulling back, and we made sure that it's in the right place. And before detaching it, we made sure with the T that we're good to go. So this was the post-deployment backup clips, which showed us that there is still the PVL is persisting despite the deployment of that device. So we had a backup wire there, so we repeated the procedure, and we deployed another device in the same manner. And when we deployed it, we again checked it with the, actually you can see the mitral valve discs, they are moving properly. This is reserved. So now again we went with the transcatheter echo, and you can appreciate it. That's it's much better than the previous one. I think it's completely closed. So we did a successful PVL closure with 2 devices, and we learned from this case that utilizing 3D images to precisely determine the PVL location, size, morphology for the procedure planning, and choosing the appropriate size and type of device based on PVL characteristics to ensure the closure, and backup wire for the backup strategy to in case of incomplete closure, as like in this case, and verifying the complete leak closure, ruling out residual shunting, and ensure that process is working normally. These are the important things which I can conclude. So thank you very much. Happy to take any questions.
Thank you so much for that great case. I love PVL closures, and so this is how I grew up many decades ago, and I actually give PVL closure the ability to do that a lot of credit for my professional success these days, because I feel that if you can do PVL closure, you can do any structural procedure. So I love how you approach that, and the double device technique, it's so important because especially when you have mechanical prostheses, the risk of leaflet impingement is high. If you were to use a single large device, would not have been successful because of the risk of leaflet impingement. It would look like it was pretty easy to cross from your end, and I also love the anchor wire technique. That anchor wire, it saves time, and it looks like you didn't have to use a rail. A lot of times I create a rail. Gagan, Firas, what do you think? Straightforward like this? I mean, I would have thought about a rail, but it looks like you didn't need it.
I don't know,
Yeah,
Paul.
I think, go ahead for us.
I was gonna say, I know you love PVL closure. Whenever I have a PVL closure is the day that I go in the lab and I know when I'm gonna get in. I do not know when I'm gonna get out. I do not know what results I'm gonna get, and I do not know what device to use. And I think the case that you have, you showed was very thoughtful. I think that you came in prepared for every next steps. I think the results are great. Luckily there is not a lot of PVLs, to be closed. I think the era of surgical valves in MAC, there was a transcatheter valve. There are some, and you've demonstrated the importance of, protecting the discs. You demonstrated the importance of having stability in the delivery. I agree with Paul. I usually do a rail just because I do not want to lose access. But you've demonstrated that it can be done, successfully in other way. And I hope that we don't have a PVL pandemic, because if we do, we're all going to be very, very busy. I think, Paul, you might know more than I do, but there is a device that is about to be FDA approved for PVL closure, right?
We hope so. The paradigm study is studying ABP4, which is available in Europe but not available in the US. And the nice thing about that is that it's oval and it can be twisted and turned. So theoretically it'll have less leaflet impingement. But one of the challenges is that in that trial, the paradigm, they require that you have to say you're only going to use one device. To me,
Right.
that's hard to say and plan for. Gagan, I know you do a lot of these too.
Yeah, great case. I think it really highlighted, all the toolbox you have to bring with yourself. PVL closure is like a box of chocolates, right? I mean, like you never know what's going to happen, and what you have to bring in, what you have to bring out. So sometimes they're quick, sometimes they're not. I think the things that were going for you in this case is that it was a lateral leak. Lateral leaks are often easier to get to and then navigate through. The more medial ones are often far more challenging. MAC is always a lot harder to navigate through. It's sometimes not a discrete hole, but it's a serpiginous kind of a track that sometimes you have to get through. And so I think that's smart. This concept of leaving a secondary wire behind is phenomenal. I think I've started to do that now for all my PVLs because you never know. You get one device in and all of a sudden you're like, well, shoot, I still have a residual leak. You got to take it out and then start all over again, put two wires in. So I think having one behind really helps save a lot of time. The one question I have for you is whether the patient had any evidence of hemolysis after your closure. There was one view where it looked like there was a little bit of an eccentric jet, small. And the problem with small eccentric jets is those are the ones that hurt you the most because it's a low volume but a very high velocity jet, and so you can get hemolysis with those type of jets. So just curious to see if you saw that or not.
Well, that was not so immediate because our patient got well. We discharged the patient within 36 hours of the procedure, and the evidence of hemolysis, I'm not sure it was not so immediate that we were there to share. It was a few months back, so I'm not sure. So, but I'm sure that we discharged the patient early after 36 hours of the procedure. Things were good.
Yeah, if the patient had hemolysis, they would have been back. So that's a good sign.
And I think to your point, Gagan, is that, if you're doing these cases for hemolysis, you really do have to get rid of all of it because it's very hard. Even just a small leak left behind, they'll still get hemolysis, and that is challenging. So some of these mechanical ones with residual leaks can be an issue. I think also it's hemolysis tends to be a little more device specific. So we stopped using the VSD devices because of the mesh. It tends to cause a little bit more hemolysis. And since we've gone to ABP2s, we haven't seen as much as long as the leak is treated well. But that's a great case. Thank you so much again for especially dialing. You get the award for furthest away. So if we were traveling, you get the travel award. So thank you, Dr. Larry. So our final but not least presentation, Dr. Warner from Georgia. Welcome, Dr. Warner, if you'd like to go ahead.
So, good evening, everyone. It's an honor to present at CVI, and we'll present our case. Just plug in a solution for recurrent mitral regurgitation after mitral clip. Honored to present on behalf of my colleagues, Dr. Barmore, Dr. Lee, Dr. Al-Khatib, and Dr. Sharkawi. So we have a 78-year-old male with a relatively extensive medical history, ESRD on dialysis, hypertension, hyperlipidemia, OSA on CPAP, and also an extensive cardiac history as well. Functional mitral regurgitation, had a mitral clip placed at the A2, P2 position back in 2022, coronary artery disease, status post PCI, to RCN left circumflex, August 2022, ischemic cardiomyopathy with a biventricular ICD in place, and severe aortic stenosis, status post TAVR with a 26 millimeter Edward Sapien valve. So presented to follow up in the structural heart clinic with a chief complaint of dyspnea on exertion. So here's our transthoracic echocardiogram. EF at this time was 25 to 30%. TAVR valve was well seated with trace paravalvular leak, but the mitral clip in the A2 and P2 position, we could see moderate to severe mitral regurgitation. It's starting the jet laterally to where the clip is placed. Mean gradient at this time was 4 millimeters of mercury at 81 beats per minute for the heart rate, and RVSP was 52. So the pre-procedural transesophageal echocardiogram, for time's sake, we'll kind of go quickly through these. Shows the same lateral jet that we saw on the surface echo here. There's just 3D renderings. So kind of to summarize what we have pre-procedurally on our TE, moderately dilated left ventricle, moderately to severely reduced function, and severe mitral regurgitation that's lateral to the previous clip that was placed in the A2, P2 position, mean gradient of 3 on the transesophageal echocardiogram. So initially for access, a 4 French micropuncture kit was used. The patient was perclosed and ultimately dilated up to an 11 French sheath. The septum was crossed with a Veracross cross system. Here's our measurement and video coming across the septum. So the initial approach, we had a wide jet. So we used the NTW mitral clip that was applied laterally to the first clip the patient had back in 2022. And so these are the images after the first clip. So there was still a moderate to severe mitral regurgitation that worsened as the procedure went on. As the blood pressure raised, we saw more mitral regurgitation. Gradient was still okay with a mean gradient of 5, but the V wave was at 43 millimeters of mercury. So after this, for the residual mitral regurgitation, a second mitral clip was applied and an NT clip was placed lateral to the prior 2 mitral clips. And here was the final result after that procedure. So pre-clip, the pressures were 52/20. Post-clip, it was 40/20. And our plan is there's still some mitral regurgitation present to do reevaluation in 4 to 6 weeks to allow the endothelialization of these mitral clips. But unfortunately, the patient returned to the hospital post-procedure day 5 with recurrent dyspnea on exertion and lightheadedness and was admitted for acute on chronic heart failure. At that time, we underwent a second mitral valve intervention at this time. So kind of similar images we had to the previous one, but showing mitral regurgitation kind of directed between some of the mitral clips that were previously placed. And here are some of the images we used our transesophageal imaging to get the vena contracta here to measure out what the defect we had between the 2 clips. So access was obtained right femoral vein with a 4 French micropuncture kit. The 8.5 French steerable catheter was used to cross this cleft. And we can see the fluoroscopy images here initially crossing the glide wire and multipurpose catheter will ultimately exchange for the Amplatz wire. Our initial approach was to use a 25 millimeter bore cardioform, and 3 attempts were made with this. We have the transesophageal images on the top, and then our fluoroscopy on the bottom. They try to pull the catheter back. Unfortunately, we ran into some issues with this approach. So kind of on these fluoroscopies, we can see we're trying to pull back the Gore device, and we're getting caught in the chordal apparatus here. So not getting a good deployment of the device. And the second issue we ran into as well is getting both of those plates to actually adhere well. So these are a couple still images on the screen right, showing that we couldn't get good apposition of the plates. And then we still had a centric jet that's seen the TE image on top at this point. So we kind of changed strategies and went for the Amplatz vascular plug, just a picture of the device from the website, transesophageal on top. 14 millimeter device was what we decided to do. On the bottom is the fluoroscopy of the device actually being deployed between the first mitral clip that was placed back in 2022 and one of the mitral clips that was placed more recently. Here's just 3D imaging showing the Amplatz vascular plug being placed. And so the thing we looked at to determine the success of our procedure was actually pulmonary vein reversal. So the pre-picture is on the right. You can see systolic reversal of flow through the pulmonary veins. And then after the Amplatz vascular plug was placed, we actually saw improvement in the systolic pulmonary vein flow. Well, it shows a couple of images are having issues there. So here's our final image here. So the final result was severe mitral regurgitation improved to mild to moderate. The pre-plug V wave was 54 millimeters of mercury, which was reduced to 28 millimeters of mercury. And then these are the TE or the transthoracic images 1 month after the intervention that showed mild mitral regurgitation. Unfortunately, he did have to be readmitted for hemolysis that was treated with folate, iron, and we increased his metoprolol as well, and he recovered from his hemolysis. So in conclusion, We presented a 78-year-old man, multiple cardiac comorbidities, that had recurrent mitral regurgitation after multiple mitral clip procedures, which was ultimately resolved using an intraclip and Platt's vascular plug. And thank you for the opportunity to present. This is Dr. Sharkawi, the structuralist, who is the primary operator, Dr. Al-Khatib, who is the imager on the case. As a fellow, they're both great to learn from. So I wanted to give them a shout out. Dr. Sharkawi helped me even edit and prepare from out of the country in Jordan. So they're both great mentors, and really wanted to give them credit for the case that they did.
Fantastic. Thanks so much for sharing that. A lot of interesting parts to that, especially trying the cardioform. I've never done that because I was never sure that you could get it to lock in place. Gagan, Firas, have you used cardioform for these between plug leaks or between clip leaks?
Not a cardioform in the mitral position. It certainly other MPLATs are like devices for sure, but always run the risk of hemolysis. But
yeah, I've tried it once, but I tried it in between a clip and a commissure, not in between two clip. It's easier to have it biased toward the the commissure, and you can lock it that way. This is this is a fantastic case, and Paul, you love plugs, and you got two in a row. And I think the importance of this case, and as mentioned before, is also you illustrated the hemolysis. I mean, this has been the the nightmare of those cases, and it's hard to predict who's going to get the hemolysis and who's not. Gagan's point is well taken. Usually, the smallest pinhole and the highest velocity jet is the one that hemolyzes, and not necessarily the one that translates with the largest volume. But quite honestly, demonstrated also that hemolysis can be treated medically just by changing the hemodynamics sometimes with the pentoxifilin and the folate, iron, as you stated, to support anemia, beta blocker, and sometimes it will make a difference. The last thing that I would say is you also have demonstrated how much we have to learn more about TEER. And, I don't think that you expected the results that you got, going into this procedure. You managed it beautifully, but it illustrates, some of the uncertainty sometimes with certain challenging anatomy. Beautifully managed, and congratulations.
Yeah, I completely agree. I have a couple of questions for Dr. Warner. Was there a gradient? Did you want to comment on any mitral gradient after putting the plug in?
After putting it was similar. It was like 5 to 6 when we did the surface echocardiogram, so not enlarged from before, and kind of consistent with a couple of case series that were out that doing these plugs that actually doesn't do that. I had one at the very end. I think there was 9 case series that came out of Minneapolis Heart, and then another 9 case series actually that came out of Cedar Sinai, and both demonstrated that there wasn't an increase in the mitral stenosis.
I can't remember if we were first or Cybele was first. I'm sure Cybele was first. but yeah, I think it's a lot of fun to put these in. I'll tell you, I did have a recent case though where it was a regret, where I actually went in, and when I was putting in the plug, I actually dislodged one of the clips and created an SLDA. And that's just because I was trying to pass a flexor sheath, and the edge of the sheath got caught on the device, and my surgical partner, Dr. Bopat, had to take the patient to surgery, unfortunately. So it's relatively straightforward, I think, but you do have to be a little careful going in and out of these. So great presentation. Any other comments, Gagan or Firas, in that case?
Yeah, just a quick question. I mean, Alex, what do you think the mechanism of the recurrent MR was after you put in those 2 clips, and then before you had to put in the plug? What do you think was going on?
The concern was that there was a cleft between the initial mitral clip that was there and then the first one that we had placed. So right between there, that was a concern that there was a cleft, is what we thought the pathology was.
Okay. Yeah, it's these cases are really challenging. I mean, sometimes you worry that whether with all the tension on the leaflets, if perhaps there might have been some leaflet injury related to the clip implants, especially the exact location where it is on that posterior side, because you didn't have any of that MR, initially, and then it kind of seemed to have just come out on its own. So you often worry, but you're right, you might have opened up a cleft and it came back from there. But either way, the deed is done. You can't, unfortunately, even if you opened up a cleft, you can't take the clip out and change plans. Well, this is a great demonstration of persistence and congratulations to you guys.
Yeah, I did note that there's a little bit of lack of redundancy. I didn't have a whole lot of reserve there in the coaptation. So we have a case poll up. If we could have the audience vote on the case favorite cases for tonight. Just as a reminder, all 4 presenters have already gotten a travel grant to CVI Austin. So we'll see all of you in Austin. So congratulations on that. And perhaps we can just collect the votes for tonight, and then we'll have that verdict soon.
And just because you use plugs doesn't mean you win.
And I don't know if you guys know, but neither Paul or us can vote. So the vote is for the audience on that call.
Almost in here. I think Tom. I think we have consensus here. Yep. Last call. Okay. Okay. Congratulations to Dr. Warner. You get a $500 Amazon gift card, which I think works in Georgia. So congratulations. But I want to thank all of you for participating tonight. And again, look forward to seeing each of you in Austin. It's been great discussion. I want to thank Firas and Gagan for their amazing comments as always and helping me through this. And thank you all. So have a good night, everyone.
Thanks,
Thank
Paul.
you.
Congratulations.
Good night, everyone.
Congratulations. Bye-bye now.